everyone, and welcome to this conference hosted by MS Focus, the Multiple Sclerosis Foundation. I'm your host, Kimani Hendricks, Multimedia Communications Coordinator for MS Focus, and today our speakers are Drs. Adam Chaifetz and Adrienne DeBerry. Dr. Chaifetz is a board-certified chiropractic neurologist. Since 2008, he has been the program coordinator for the Comprehensive MS Center in the Department of Neurology at the Jacksonville campus of the University of Florida. He manages the program through the interaction with patients, providers, and ancillary staff personnel. He is also a strong advocate for patients and interacts with governmental relations representatives and local federal legislature. Dr. Chaifetz has been in clinical practice since 1987. His expertise has always been in a collaborative medical environment. Dr. Chaifetz has run and managed the largest chiropractic practices in Jacksonville. The first chiropractic rehabilitation center director in Jacksonville, Dr. Chaifetz has always been at the epicenter of a collaborative care with his patients. Utilizing medical physicians in practice, his patients have always benefited from a thorough, comprehensive approach to healthcare. Dr. Adrienne DeBerry is a clinical pharmacist at UF Health Jacksonville and is a clinical assistant professor for the University of Florida College of Pharmacy. She received her doctorate of pharmacy from the University of Florida College of Pharmacy in 2012. Upon graduation, she has completed 2 postgraduate residency programs, with the second specializing in ambulatory care. She is board certified in ambulatory care pharmacy and certified in specialty pharmacy. Her areas of practice include neurology, pain management, and specialty pharmacy. She has held leadership roles in multiple professional pharmacy organizations and is passionate about patient education. And today the speakers will discuss the changing landscape of MS treatments, and we will leave time at the end of their presentations for questions and comments. Meanwhile, Dr. Chaifetz and Dr. DeBerry, thank you for being with us, and I'm going to turn it over to you, Dr. Chaifetz, to start us off.
Alrighty, thank you so much, Kimani, and welcome everyone to our presentation today. I feel, first of all, honored and very appreciative to be here. And I think it's really wonderful that we also have the expertise of Dr. Adrienne DeBerry. She's our clinical pharmacist, and in addition to all of her clinical work that she does and her residencies that she's done, she's also responsible for starting our specialty pharmacy, which directly serves our neurology patients and especially some of our MS patients. So the presentation that we're going to do today is really going to be from both angles. Dr. DeBerry is going to tell you about the science of some of these new medicines that are coming out. And what I'm going to talk about, because I'm also a provider, but my main job is an administrative job here at the University of Florida. So what we want to do is present to you kind of what's happening in the MS world right now. At a comprehensive MS center, we serve many patients. And so this is a very crucial time of the year, the beginning of the year, where patients need to know essential things no matter what your circumstances are. I'm going to go through some steps that I think are going to be helpful for most people. So here we go. So the first thing that I want to talk about is when we start the new year, patients have a responsibility as best they can to notify an office if they have an insurance change. And the reason for that is because the way it has, the climate for obtaining authorizations for medications and procedures has gotten very tedious, and the insurance companies, unfortunately, have the upper hand in the entire process. Now, for patients who do not have a new insurance, but are on some sort of patient assistance program. When you think about it, most patients have to have assistance in one way, shape, or form in order to get their medications, whether it's copay assistance or completely free medication assistance. And so the patients who fall into those categories are going to be mostly our Medicare patients and those patients that maybe don't have insurance or are underinsured. So if you want to help yourself stay on drug continuously, please let the staff in the office know as quick as you can any changes, whether it's from one insurance to another, or we're going to talk about a very important change coming up in the future, which is when a person goes from some type of insurance to Medicare. And things can really, really get muggy when we see the differences of what can happen. So let me explain some things to you. And my comment is, the sooner you get the information to the office, you will not get a face like this fish here looking at you when you tell them you're out of medicine and you have new insurance. So now with Medicare patients, here's a situation with Medicare. Most Medicare patients have high copayments. So when you have Medicare, and I'm talking straight Medicare, you have to have a Part D supplement plan because most prescription drugs are not covered by Medicare. Now, does that mean all MS treatments are not covered by Medicare? No, because some infusions are covered under the medical portion, and the medical portion for Medicare would be Parts A and B. So why do patients who are on Medicare get into the most trouble? Well, we're going to go through some of the steps that put patients in jeopardy of being put off drug. And so when this happens, you have to be really prepared and think quickly on how to resolve this. So let's look at most of your Medicare plans. Now everyone here has seen celebrities on commercials. And I don't recommend purchasing products from celebrity endorsements because when you think of them, probably they're the ones who need it the least. So when you look at a Medicare plan, you have to make sure that you go through all the steps to make certain that your specific drug or treatment is going to be covered under the plan you choose. So you see these commercials for these all-inclusive Medicare plans, right? And it offers things that traditional Medicare doesn't. But from my experience, it can leave patients with copays of between 10 and 25%. So think about that. If your medication is an average medication, and you know, you can find out how much your medication is by looking it up on GoodRx. Okay, if you just go to GoodRx, put in your med, if it's not an infusion med, you'll be able to see that the drugs run between $7,000 and $9,000 a month. So what do I do to get my medications? Well, if you have a commercial insurance, Blue Cross, Cigna, Aetna, you're not on Medicare, you're not on Medicaid, okay, what you need to do every year is contact the drug company, whoever makes the medication, and you need to re-enroll in their program. The reason you do that is because they are extending to you the courtesy of a medication that costs, well, sometimes as much as a house in certain areas of the country. So they expect you as a patient to sort of be responsible and give them a call or fill out the forms that need to be done and completed in a timely manner. Now, one of the things we've learned over and over again is that patients who are brand new to multiple sclerosis diagnosis and just receiving medications for the first time, or they're changing insurances and pharmacies, do not ever, ever accept delivery on a medication unless you're told what the price is going to be. We unfortunately had a patient accept delivery and they were given a bill of $7,500. And it wasn't something that we were able to reverse or help them with. And it turned out to be quite a problem for the patient. So please, 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 before you do anything, make sure you're very knowledgeable from your specialty pharmacy what your obligation is. This is why copay assistance and patient involvement and knowing the process and getting your copay card will make this process seamless. Okay. Now, for patients who have Medicare, the people who are in trouble, the ones who are the most vulnerable, are not only patients with high copays, but we're talking about patients on drugs that have gone generic. Okay, so those medications are glatiramer acetate and dimethyl fumarate. Those are the generic versions of Copaxone and Tecfidera. Now, when these medications went generic, assistance for Medicare essentially dried up. So some of the manufacturers of the generics may not be offering free medication programs. For the manufacturer of dimethyl fumarate, the last count, there were 10 different companies that were making that drug. So it is so difficult to get any kind of funding for generic drugs on Medicare. That is one of the biggest issues that we face right now, every day with our patients. So what do you do in that circumstance? It's a clinical decision. You have to choose between being off drug totally or talking to your provider about potentially switching to another medication that might be a good fit both clinically and financially for you. Okay. Now, as a clinician, I can tell you, all my neurologists do not like to switch patients because they can't afford their drug. That's not a clinical reason to do it. And unfortunately, patients have to understand that when we try to get it approved by their insurance, if there's not a clinical reason to switch a medication, sometimes we have a really, really difficult time in getting them to comply. All right. Now, from the first couple of slides, you may have noticed that I like the ocean. And one of the things that I do in my personal life is I'm a surfer. And one of the things that people don't realize about surfing is when you see these people surfing on big waves, you say to yourself, how the heck did they get out there? Well, when you look at this wave, you say to yourself, you either have to go through it or over it, right? And in my life, I've been hit by these things so many times. And I put this picture in there because I want you to imagine being on a surfboard, paddling out, and this thing literally just coming upon you with tons of water. That's what it can feel like as a patient when you're trying to get your medications. This is the feeling that a person has to where they're struggling and they can't really get anywhere. So we know from our end, it can be really challenging and frustrating dealing with re-enrollment every year. But I got off the phone with a patient this morning that didn't even know she was on a free drug program and had no idea how her medication showed up in the mailbox every month. So I beg you all to please store this information, because without it, it could seriously interrupt your medication regimen. Now, when you're transitioning from a commercial insurance to Medicare or anything to Medicare, Maybe a person is awarded disability and is given Medicare immediately. If that happens, this is where you get the choice of your type of Medicare program. You can take straight Medicare with a supplement, but that supplement is going to cost you additionally. These Medicare Advantage plans may be a good fit if it's affordable for you. Okay. Once again, before you change insurances, it never amazes me that patients change insurance and don't ask if their drug is covered. So make sure you do that. All right. And just remember, just because Joe Namath and Joe Montana and JJ endorse products, that doesn't mean you should go out and buy them. So as a patient, you want to use a very methodical approach to care. And this is what I recommend wholeheartedly. The first thing is be regular with your care. From a clinical perspective, patients have to understand that the insurance is who has the upper hand in the process, and they determine largely what the patient receives for their care. So you need to be regular with your office visits, your labs, your other appointments, because they request clinical documentation to substantiate your continued therapy or treatment. All right. Understand what a formulary is. So if you change insurances from one to another, believe it or not, the list of multiple sclerosis drugs that they cover could change dramatically. Make sure if that happens that your drug is going to be covered. And then take all the steps to know your options. So depending on the type of MS you have, patients on certain medications that have gone generic, they're not going to be able to get brand medicines unless it's a very rare circumstance. And one caveat or one circumstance I'm aware of is on the Medicaid formulary for Florida, Tecfidera is still on the formulary, the brand, not the generic. So it's confusing to a lot of folks because that's an outlier when it comes to most of the insurances. Okay. And then the problem, again, when we talk about Medicare patients, is we have some of these companies that have decided to get into multiple sclerosis care, but they're not offering very substantial copay options for patients with Medicare. So say to yourself, what kind of patient are you? Do you understand coming in and getting your labs done, or do you have to be called and or your treatments held up because you didn't get things done? And that can be frustrating, both from the patient standpoint and from your provider standpoint. And it's amazing how many patients don't know where they get their medications. And so I keep putting that out there because it's very, very, very important to know. All right. So who needs improvement? Patients that aren't regular. We have patients that haven't been in 2 years and demand a refill. Okay, very good. Obtaining and staying on medications has become so complicated and patients are not aware of what to do. So they throw their hands up and they just don't get a medication or they stop it. Patients don't understand the importance of regular therapy, or they augment the therapy schedule to what they like. Well, I only take 1 a day instead of 2. Or worst of all, there's been the patient just drops off a treatment because their provider left, or they've had a change in insurance, or maybe they just have dropped off treatment. So that's important because the integrity of a patient's continuity of treatment is going to depend upon how cooperative a patient is. Now let's talk about COVID for a minute. Do we honestly know what's happening? We don't, because there are areas where we see a lot of hospitalizations and we see a lot of people who are afflicted with it. So to understand your risk is to understand, number one, the type of MS you have and the type of therapy you're on. Because if you have an aggressive form of MS and you're on an infusion type therapy, especially ones that are immunosuppressive, then these can have a lot poorer outcomes if a patient gets COVID. So our recommendations are to vaccine when you can, to obviously use social distancing and all the tools that you have, and mask. All right, now when we talk about delivering medical care, everybody wants to get back to normal. We all do. For a short period of time, it seemed like we were able to relax and do in-person events, and then things have gone back to more of a virtual format. Now, even though the pandemic is relaxing, you all still have to be very careful, but you also have to be cognizant of the fact that neurologists need to examine patients, and the more frequently, the better, because that's the only way they can physically assess your condition. So those patients who have been spoiled and it's been over a year and you've received all your telemedicine visits through virtual contact, it really is optimum for your neurologist, nurse practitioner, PA, whoever your provider is, to physically examine you, because the neurologic exam is an extremely important tool in assessing a patient's progress or lack thereof in clinical care. All right, so now as a patient, I'm going to give you some things that you need to understand. You need to understand the type of MS you have. You need to understand, given that type of MS, what options you have for treatment. So safer options that are out there may be very, very safe in the COVID area, but may not be efficacious or strong enough to tackle your condition. So one of the problems with being on medications that deplete the immune system is that when you change the person from one drug to the other, there can be a period of time to where you have to wait in order to start that new drug because of the white blood cell count being depressed. Dr. DeBerry is going to talk a little bit more about what's in the pipeline. And given the scope of what's happening in the development of treatments, we're going to see so many options coming up. And I'm happy to see that there are going to be more options for primary progressive patients too. But generally speaking, just because new medications and therapies come out, that doesn't mean that, that things are going to be approved. So we want to make sure that insurances get on board with this. Whatever you do, the staff at your provider's office, the staff at your infusion centers, the staff at your PT's office, make sure you understand how important they are and how hard it is sometimes to go to battle with these insurance companies who literally make our lives next to miserable. Keep in mind that their timeline is a lot different than the medical timeline. If we mark urgent, they sometimes have a different timeline. And one of the things I want you all to think about is utilizing your clinical pharmacists in your community, in your MS center, to understand the specificity of your medication, the interactions of safety, and how you fare in the COVID area with the med you're on. Okay, and promise me and your family you'll stay on top of your prescription dates and know when you need to renew them, because most likely authorizations and applications and things like that will have to be done. And more importantly, whatever you do, don't neglect your mental health, because in your daily routine, you've got to take time to find things that are going to be helpful, positive, impressive. So smile, get outside. Aromatherapy is unbelievable with massage for relaxation. And then utilize whatever meetings you can to garner as much information about what you should and shouldn't do. The MS Foundation has been incredible in delivering unbelievable education for us. So your MS toolkit, I recommend you either get a folder or a 3-ring notebook with those plastic things that you can put pages in. You want to start compiling your medical records. You want to know what your MS diagnosis is. You want to know what company makes your medication and what their contact is. You want to know where your specialty pharmacy is, who their contact is, and if you're on a free medication program. You want to maintain copies of patient assistance applications, and then you want to always be regular with your times and your places with your appointments. So the best way I can describe it, since I love surfing, is you don't just jump on a surfboard and you're out there doing it. It's a process. And as a patient, this might be a lot to consume. So the best way to do it is just to jump right in, take some of the tools that we're giving you, and then you have the knowledge to go forward and make it work for yourself. So I appreciate your time, and I'm going to hand it over to Dr. DeBerry now, who's going to get into her portion. So I thank you so much.
Thank you, Dr. Chaifetz. Can everyone hear me okay?
Yes, we can hear you.
Perfect. I'm going to go ahead and share my screen. Okay, so for my portion of the talk, we're going to focus mainly on the MS medications. And I specifically wanted to highlight one of the drugs that's currently in the pipeline for development. And I did see that question by Ms. Lori, and I'm going to address that in this presentation. So I have no financial interest to disclose at this time for this presentation. And I wanted to start with this quote. To know even one life has breathed easier because you lived, that is to have succeeded. And that's a quote by Waldo Emerson. I wanted to kind of keep that at the forefront of our mind for this conversation, because this is why the MS Foundation does what it does. And I wanted to thank you all for coming out and being able to participate in these seminars and really get something out of these sessions. So I'm going to start with a brief kind of background to make sure we're all on the same page about MS history and MS pathophysiology. That way we better understand how these medications work. So MS is a condition that was founded a long time ago and affects over 400,000 people within the United States. It's something that's very financially impactful as well as physically impactful to those who suffer from this condition. And there's been a multitude of causes. There's not really a definite pinpoint of, yes, this actually causes multiple sclerosis, but it's almost like a specific symphony of multiple factors that can contribute to the development of MS. It can range from immunological factors, environmental factors, as well as infectious disease factors. More recently, there was actually a study published this year in regards to the Epstein-Barr virus becoming more and more implicated in its role in the development of multiple sclerosis. If you have time to look into that, it's actually data compiled from military data information that shows that there was a strong link between the Epstein-Barr virus presence and those that were found to have multiple sclerosis. It's not necessarily a one-to-one causality, but they did find that that particular infection, which can be pretty rampant and found in about 95% of the population in general, is linked in some way to this combination of factors that triggers development of MS down the road. So what went wrong? Well, we know it's a condition of a faulty immune system, and the immune system has a number of different components. So when we look at this slide here, it kind of gives you an idea of some of the pathogenesis of multiple sclerosis. So to the left on the diagram, you see the brainstem. They can kind of see those lesions, so to speak, or target areas that can happen within the actual brain or along the spinal cord. And these particular lesions may be caused by the T cells and B cells being overactive and mistakenly attacking the nerves, thinking it's a foreign object or a foreign virus or a foreign bacteria, and causing damage within the central nervous system. This damage then translates into physical abnormalities or disabilities for those patients affected. And something interesting that Dr. Chaifetz had mentioned was making sure you understand the type of MS that you have, as every type of MS is not always treated with the exact same medications. So this slide kind of gives you an overview of what happens in the different types of MS. So relapsing remitting MS is the first block, secondary progressive is the middle, and primary progressive being the last. So as you can see, as time goes on along the horizontal axis, which represents, again, time, and then the vertical axis represents the level of disability that the patient may have. So over time, a patient may have frequent relapses within the relapsing remitting MS style, and they may return close to the baseline before they relapse, or a little bit more disabled post the relapse. In secondary progressive, it's kind of a combination of primary progressive with worsening disability, as well as a mix of the relapsing remitting. And with these terminologies, you may hear active or non-active also added into the description of the condition. Clinically isolated syndrome, or CIS, is sometimes thought of almost like a precursor, but it's not really a precursor to multiple sclerosis. It's when someone has an incident, whether it be a lesion in isolation or some type of episode in isolation with no further evidence to pinpoint that it is indeed multiple sclerosis. And usually the way to differentiate CIS from true multiple sclerosis is to do a spinal tap and check for something called oligoclonal bands within the cerebral spinal fluid. So when we talk about therapeutic approaches, a lot has changed over the last decades with respect to treatment in MS. In general, it can be broken down into these four categories, with injectables being used, oral treatments, infusible products, or drugs that may be used for symptomatic treatment, such as Ampyra. This slide depicts a timeline of some of the FDA approvals of drugs that are used to treat MS. So in the early 90s, the big bulk base of what we had was the interferons. And the interferons were good for what we had back then when we didn't really have a lot of options. So interferons sometimes would make patients feel kind of yucky, almost having flu-like symptoms, but it did work at helping reduce some of the severity and worsening of their MS. Fast forward to the 2000s, we see different formulations of interferons, whether it be dose different in the subcutaneous level or in the muscle level, as well as the frequency of dosing per week. So that did provide some variability. Some of the agents were allowed to be out of the refrigerator for a little bit longer than the others. So there was a little bit of flexibility for patients. And also we saw with Tysabri infusions being kind of the first, quote unquote, so to speak, infusible product that was FDA approved for the treatment of multiple sclerosis patients. So again, we still have the bulk base of interferons within the early 2000s and the addition of the infusion. Now fast forward to the 2010s, and 2010s was booming for FDA approvals of MS treatments. This is when we really saw the bulk of the oral medications being FDA approved and available for patients. So this really proved to be a game changer. So patients no longer had to inject or had to have an infusible product. This was something they could take regularly at home and you know, take along with their other medications. And we do have a number of different classes within the oral treatment classes, which I'll go over in a little bit. But as you can see, the 2010s was really booming for us. Fast forward to the 2020s, it still continues with new FDA approvals for oral medications. With last year seeing the addition of Ponvory or Pranicamide being added to the arsenal, as well as the introduction of subcutaneous Kesimpta in 2020, which was a good option for a subcutaneous injectable and B-cell based therapy. So that is the only current B-cell based injectable therapy that we have available on market right now. Looking ahead, we have a number of agents that are in the pipeline. Today, I'm going to actually concentrate more on Ferraliumab, which is a monoclonal antibody we'll talk a little bit more about later. When we look at the MS treatment classes, again, we have a number of different options. And what's important to remember about treatment classes is that if a patient fails one drug, they may not necessarily fail all the drugs in the treatment class, but then again, they may also fail all the drugs in the treatment class from not having a good result on that one individual drug. So it really just depends on what the issue is. For example, if a patient were to have like an allergic type reaction to dimethyl fumarate or Tecfidera, in our clinical role, we would assess that patient and say, okay, the issue that's caused by this medication could be very severe and dangerous for the patient. So let's steer clear of this class and maybe switch to another class in the setting of a patient having an allergic reaction. So it's good to know that there are options available for patients when maybe one doesn't fit their type of MS or one doesn't work well with them side effect wise. Fast forward and thinking about where we first started with interferons. Interferons kind of hit a lot of different targets. They did a lot of different things that overall the summation was an increase in the anti-inflammatory components of the immune system and a decrease in the pro-inflammatory immune system components. This slide can look a little bit overwhelming, but that's kind of the gist of what I want you to take away is it tipped the scales from pro-inflammatory to an anti-inflammatory state for our patients. Now, when we look at infusion treatment products, kind of that's the more modern day roles where we see newer products still being developed and the technology getting a little bit more sophisticated for these particular agents. With regards to infusion treatments that we have available, we do have monoclonal antibodies that affect B and T cells that are available for patients who have MS. So Tysabri, kind of the oldest kind of goodie reserve that we have here for these three infusible treatments, with each of them having a monoclonal antibody that is targeted for a specific receptor subtype found on certain cells within the immune system. So we have Tysabri, Limtrada, and Ocrevus. A number of you on the session today may actually be using some of these products. So these are considered monoclonal antibodies. Now, we heard a lot about monoclonal antibodies over the last 2 years, especially in the setting of COVID. For some of the population, COVID and the COVID pandemic was actually the first time they've heard about monoclonal antibodies. But monoclonal antibodies have actually been around since the late 1970s. So the technology of a monoclonal antibody is not anything that's new, but it's something that we're strategically using to target different receptor subtypes or different components of targets that we find within the immune system or within the body. So what is a monoclonal antibody? Well, in the scientific community, you may see these antibodies depicted as a Y shape. And these Y shapes have different utilities, and they're basically helping to either target something for elimination by your immune system. In this setting of, for example, COVID, when you hear these monoclonal antibodies used against COVID, these antibodies are being infused and targeting the COVID cells for elimination by your immune system. We call them MABs or MABs for short. You may also see that used in the drug name to identify a monoclonal antibody. I wanted to highlight Ferraliumab, which is a monoclonal antibody that is currently in development for the treatment of multiple sclerosis. It is considered a fully human anti-CD3 monoclonal antibody, which means it's basically specifically targeting that CD3 receptor type that's on certain T cells. And it has a huge role in how the T cells continue to grow or propagate down their line, as well as their involvement in making sure regulatory T cells work like they're supposed to. It is being developed by Tiziana Life Sciences, so you may Google or read about that in the news. Particularly recently, there's a lot of discussion about it. And it's being developed for multiple disease states, including multiple sclerosis, Crohn's disease, and a number of rheumatological conditions. They're looking at the use for this as well. Multiple routes of administration are really what make Ferraliumab attractive as a treatment agent in multiple sclerosis. And phase 1 clinical trials are currently being planned, although they're not actively recruiting right now. So when we look at the monoclonal antibodies, kind of where we first started. So the far left, OKT3 or mirromad, was kind of like one of the first monoclonal antibodies that was actually developed. It was actually used not for multiple sclerosis, but in the transplant world was the idea of where they were going to use this to help reduce transplant rejections. What they found is that it caused a lot of side effects. It was actually developed more from like a mice origin in its development and was not considered a fully human monoclonal antibody. As our technology got better, we were able to almost purify or streamline how these monoclonal antibodies are composed. The more foreign an antibody or a component looks to your body, sometimes the more it can trigger an immune reaction. So we saw a lot of immune reactions with mirromad, making it not an ideal candidate for administration to people. Fast forward to the far right, we see Ferraliumab, which is completely in the blue, meaning it's a completely humanized, fully human monoclonal antibody with less likelihood of triggering an allergic reaction or some type of immune response that would be negative in patients. The big deal about this particular agent is it has multiple routes of administration. So you're no longer tied to having to just get an infusion, because right now we have monoclonal antibodies that are specific for infusible products that we see with the Tysabri, the ocrelizumab, and the Lemtrada that we have available. This actually allows it to be administered orally or via a nasal administration. So ideally, in the population for multiple sclerosis, they want to use this drug as an intranasal spray. So as of January 2022, they officially have enrolled a second patient in treatment. So there's a kind of a backdoor pathway that a patient can get access to a medication that may not be FDA approved, but depending on their health condition and the availability of other drugs on market for their disease state, they may be eligible through a specific FDA pathway, which I'll talk about in a minute. But Harvard through the Brigham and Women's Hospital, they've actually enrolled 2 patients into receiving the Ferraliumab treatment, and they're monitoring them in 3-month increments. So the first patient completed their 3-month data reporting, and there were no alarming side effects or tolerability issues, so they were granted approval to add a second patient for use of this intranasal product. And they did see documented reductions on imaging, so it is helping that particular patient that was first enrolled, so more to come. Again, this is very early stages for Ferraliumab. But what's important to note is it's being targeted for secondary and primary progressive patients. The first 2 have been secondary progressive patients, but this is really kind of shifting our mindset and looking at some of those more severe patients with progressive disease and getting to market some other options for them. The way that these patients have been able to access Ferraliumab is through something called an FDA Individual Expanded Access Program. So again, this is only for drugs that are not FDA approved that may be under investigation still. This pathway actually was established in 1987, which it kind of really went into effect in the late 1990s. But it is a good way that patients that have severe illness can access investigational treatment. And one of the caveats is that these patients have to have no satisfactory alternatives for use for that particular condition. And it has to be a serious healthcare condition, which multiple sclerosis in this case is identified as one. A way you would access this would be through your physicians. They actually have to complete the access and paperwork, and it's very lengthy and involves the investigational review boards of the hospitals or the facilities where they're working at. So it is a very rigid and stringent process, which also is one of the factors that doesn't make it super common that it's used, but it is a pathway available because the FDA does recognize there are a lot of barriers in place, sometimes, most of the time for good reason, for accessing investigational drugs. When we look at the currently approved drugs for secondary progressive MS, we do have a lot, but at the same time, it's not really a lot. Some of these drugs do have a plethora of side effects that may exclude a patient from that particular class. So for example, if a patient has underlying cardiac conditions, then sphingosine receptor modulators may not be a good option. So things like Zeposia or Ponvory, they may be not able to use those agents. When we look at the Ferraliumab timeline, this kind of gives you an idea of where we are in the stages of development of this drug. And again, it's very early on in the clinical trial process as of right now. Something interesting to note is the way that Ferraliumab works, they've actually found that the intranasal or the inhaled versions do work better on patients that have COVID. So we do see Ferraliumab being used in COVID research as they found that it helps reduce some of the inflammation directly within the lung tissue by targeting that CD3 receptor on those T cells. So when it comes to multiple sclerosis, I don't necessarily think it's time to retire some of those injectable agents, those oldies but goodies, because some people may be on interferons for years and it does well and plays nice with their MS. So there may not be a reason to rock the boat just yet for that. But there are a number of patient considerations that you want to take into effect, such as the administration route, as some patients may have dexterity issues, whether or not the patient's in their family planning stages, as some medications may or may not be used while you're trying to conceive, and then previous failed treatments as well as comorbid conditions. And when we think about approaching treatments for MS, there's a wheelhouse of escalation versus the induction. So are you going to hit it, so to speak, with the big guns, or are you going to kind of start from the low collateral damage options and work our way up if we need to? So when selecting the best DMT, it's not something that is necessarily going to be the best for every single patient. because everyone's MS is a little bit different. But keep in mind, and I want to encourage you to be optimistic, as there's a lot of new drug targets that are being identified in multiple sclerosis, which opens the door very wide for new options for patients that may previously have not had a good outcome on other options. And then let me make sure. Sorry, my thing is a little bit off. Okay. So in conclusion, multiple sclerosis patients do have a lot of treatment options. The treatment selection should really be based on the individual's level of MS aggressiveness, because one person's MS may be more aggressive than another. And depending on the subtype that you're diagnosed with, you want to make sure you're matching up your drugs appropriately for things that are efficacious for your particular type of MS. You also want to pay attention to comorbid conditions, as that can play a role in the decision making. And keep in mind, the treatments are definitely getting more sophisticated when it comes to what options that we have in place. And that's all I had for you all today for my portion.
All right. Thank you so much, Dr. DeBerry. Thank you, Dr. Chaifetz. And if any of our listeners have a question or would like to leave comments, you can do so by either typing them into the chat or the Q&A boxes in Zoom. You can also raise your hand if you'd like to speak directly with Dr. Chaifetz and DeBerry. And if you're on Facebook Live watching and you have a question, you can just type it below the video. But I do see a question in Q&A. I saw that before something appeared in the chat. It's from Judy. She asks if there are any recommendations for cognitive issues with MS or who offers treatment.
So in our opinion, I think the best person to assess cognitive issues in MS would be a neuropsychologist. And these are psychologists that are clinically trained in cognition and do very lengthy tests in order to assess a person's cognitive status. And something like that is very geographical. It depends on where you live. If you live in a bigger city, you'll probably find it a lot easier than a small rural setting.
Thank you, Dr. Chaifetz.
Sure.
It looks like in the chat, someone named Claire is watching from the UK. Wow. She says, super interesting. Thank you so much. Melissa asks, is there a timeline for a cure for MS?
So from what I've seen, there's no timeline for a cure. There's changing information, and we're gaining more insight into the diagnosis and as to what individual factors play a role in those individuals who do develop multiple sclerosis. So one interesting thing, like I mentioned, the Epstein-Barr virus being recently more and more implicated in one of the triggers of MS, is there's discussion of using the mRNA vaccine technology to target Epstein-Barr virus. And hopefully, again, this is very theoretically down the line, and hopefully prevent people from triggering over into developing MS who do get exposed to the Epstein-Barr virus. But this is very, very early discussions and very preliminary research at this time for that.
I was actually going to ask you what the link was between MS and Epstein-Barr virus, because I know you did mention it, but.
So the thought process is that the virus the Epstein-Barr virus is actually the virus that causes mononucleosis or kissing disease. So once the virus is within the body, the thought process is it can remain latent and can cause a number of the B cells to basically get confused and not work right. So they think the Epstein-Barr virus can mimic other immune system cells and then kind of accidentally trick the immune system into attacking the myelin sheaths and different nerve components. But it's about 4 or 5 different mechanisms that they think it works at, but they have definitely said, all right, there's something there with that link. But normally the Epstein-Barr virus, aside from, causing mono, doesn't typically cause a whole lot of issues for most people.
Got it. And we have some thank yous in the chat just saying this is a great presentation. There is a question from Desiree on Facebook, and she wants to know, how do we not blow our nose and the med is lost? I don't know what that means.
That's an interesting question. We currently use intranasal spray technology for things like common allergies, like fluticasone, people who have severe sinus issues. So the thought process for this particular drug, they're looking at a daily dosing and they're looking at a 3 times a week dosing for it. So it wouldn't be something that you would constantly have to spray in your nose and worry about. When you use an intranasal spray, the molecules are so tiny, it gets absorbed transdermally within the nasal passages and goes directly kind of into the vessels and different things that flow in the nose. So it's not something you have to be super worried about it getting lost if you happen to sneeze 20 minutes after or blow your nose. So the technology is very advanced. You won't necessarily lose your medicine if you have to blow your nose, but good question.
Got it. I'm not sure, Casey, if Judy's question in Q&A is for us specifically or
Yeah,
for
I can answer that. It'll be a very general answer. Judy, it's gonna depend on the medication you're on. Because the way foundation funding works is it's usually funded by the company that makes your medication. So some examples of foundations will be the HealthWell Foundation is one, HealthWell, one word, NORD, N-O-R-D, National Organization of Rare Diseases. And then make sure if your drug is a brand drug that does not have a generic, that you call the company and ask them which foundations they're funding or what their plan is for continuation of drug. This is probably the most critical circumstances we deal with on a daily basis. And unfortunately, sometimes it requires a medication switch. And that's something that would have to be determined by your provider.
Cassandra asks, is there a term for or I don't know if she means term or not, but she says, is there a term for sociological effects caused by a physical or physically induced disorder?
You definitely can have a lot of social impact from having your physical disorder. The specific term currently escapes me, but yeah, you definitely can have that from some of the conditions. We do see a lot of depression within our clinic too from some of our MS patients. And then also sometimes people physically don't look like they're ill or have any challenges, and that can be frustrating for others who don't really understand the condition, or maybe they have a parent that's affected by MS and there may be a teenager and are looking at other kids whose parents may not have some of the same challenges that their parents have and don't really understand. But I do encourage you to make sure that you have a team-based approach for your care, because it does make a difference in having those different backgrounds, whether it be the psychologist, the neuropsychologist, as Dr. Chaifetz mentioned, the physical rehabilitation team. It makes a huge difference to have all of those aspects looked at as part of your clinical progress.
Yeah.
I'd like to jump in and go back one question. I just wanted to mention really quickly that the foundation does have a list of organizations that do assist with copay funding. So if you'd like more information on the foundation funding aspect that Dr. Chaifetz talked about, you can email support@msfocus.org and ask them for the copay funding list. I'll put that in chat as well.
Thank you.
And then just to put a plug in too, there's a website, the Patient Assistance Foundation put in place called Fund Finder. It's free. If you sign up with your email, it is almost like the Google of copay assistance and foundation help. And you can actually sign up for email triggers. So it will send you an email to let you know when any multiple sclerosis funding pops up. And that's in real time availability. So I would encourage you to look up Fund Finder through the Patient Assistance Network.
It looks like there's another question that popped up in chat from Lori. She asks if you can suggest where info in Canada can be found.
That's a great question. I'm not sure about Canada.
I'm sure the MS Society may have some connections in Canada. But you know, with their medical system, their approach may be a little bit different than the way that we treat. Like in England, they use a lot of oral immunosuppressants over some of the FDA-approved DMTs that we use here. So I don't know. That's a good question.
Yeah. Well, I don't see anything else in the chat or Q&A that's new. Casey, do you see anything else from, oh, never mind. Oh.
But I do think just like in America, that anybody who has access to an MS specialty center is going to benefit probably the most. Because we have a setup that's really unlike most practices, and people like Dr. DeBerry, myself, we've been doing this a while. We're a team, we're coordinated, and I think that means a lot, not only from the standpoint of the diagnosis of the condition, but the follow through in getting things done for people is just as important. So we appreciate all the questions and inquiries from everywhere. And we hope that this has been really helpful for everyone. And
it looks like we do have another question from Judy. She asks, do any of the current MS medications work for seizures, or are steroids the only thing that works?
So the current medicines, none of them are FDA indicated specifically for the treatment of seizures. The thought process is if your MS activity and the inflammation is what's contributing to your seizures, by treating the MS, it may help calm it down. But normally you would want to look for more seizure-specific medications if that's an ongoing issue.
And that's also an excellent point, because I remember doing a research analysis years back, and believe it or not, MS patients are 30% more likely to have seizures. So what Dr. DeBerry said is very frequent in our practice, to where we will send that patient to an epileptologist here, and they'll be managed from both perspectives. Because a lot of times epilepsy is like MS. It's complicated. So.
Thank you. Well, it looks like that's all the time we have for now. If anyone missed any part of the conference, it will be available for replay on Facebook. So after the conference ends here on Zoom, just wait a few moments and you can go straight to the Multiple Sclerosis Foundation Facebook page and watch it from the beginning. It also will be available on YouTube within a week or so. So we thank you for your patience in advance for that. Our next conference will be on Thursday, January 27th at 7 p.m. Eastern Time with Dr. Megan Weigel, and her topic will be how to change your life for the better with MS. And we thank all of the attendees for participating and for your comments and questions. And thank you so much, Dr. Chaifetz and DeBerry. It's good to see you guys again. And we hope you all stay safe.
Thank you so much. Everyone have a great rest of the day. Thank you.